شباب مساء الخير، بونسوار جميعا. بعتقد صار فينا نبلش. With great pleasure we will proceed with the next ABC course. طبعا مثل ما شفتوا بالسموك حطينا we will rise again. يعني بعد كل اللي صار ببيروت وشفنا كيف الأبنية والبيوت والعيادات تهشمت، الله يرحم اللي ماتوا. Nevertheless we will continue. أنا كان اليوم الصبح عم بحكي مع بعض الزملاء عم بيسألوا عن الوضع، قلت لهم بدنا ننام عشية ونقوم الصبح ونمشي وما نفكر، لأنه إذا بدنا نفكر رح نتعب. Saying that نحن we will start this web session. أنا by the way لابس اليوم أحمر as RBCs، يعني since our subject هو blood. اليوم نحن علون blood. فإذا we'll talk about the chronic lymphocytic leukemia. This session is, or this course is supported by a grant from AbbVie. هلا هون أنا I will leave the lead to Dr. Ahmed Ibrahim to start by presenting the speakers and the topics. Thank you very much.
I would like to thank you, Professor Farhat, for inviting me to be the chair of the first session of this meeting, and to thank AbbVie for supporting this meeting on CLL. My job is to be the chair of the first session. It's almost 55 minutes. So we will have two talks. The first one will be done by Professor Nizar Bitar. He is Professor of Hematology, Oncology, and Medicine at the Lebanese University of Beirut and Chair of the Hematology Oncology Department at Sahel Hospital. He will talk about CLL, an overview on CLL diagnosis and the prognostic factors. And then we will have a second presentation by Professor Joseph Attan. He is the chair of the Hematology Oncology Department at Hôtel Dieu de France, and he is Professor of Hem Onc and Medicine at Université Saint-Joseph. He will talk about the evolving therapies of chronic lymphocytic leukemia. So we are happy to hear Professor Nizar Bitar first talk about overview CLL. Please, Nizar.
Thank you, Ahmed, for this kind introduction. First of all, I am happy to be among you today. Would like to thank and to congratulate the organizer for this night meeting, and thanks AbbVie for giving me this opportunity to be here today. Okay. I would like to give an overview on chronic lymphocytic leukemia. يمكن دكتور فادي فرحات ضبط معه اكثر لو لبس ابيض. لوكيميا it mean لوكوسيميا، يعني ابيضاد الدم، لما الدم بصير ابيض. هي لوكوس يعني ابيض، وايميا يعني بالسان. لوكيميا هي lorsque le sang devient blanc. خاصة بالchronic lymphocytic leukemia where the number of leukocytes can reach sometime 200, 300,000 or even more. CLL affects a lot of people in our society. In USA, for example, the new cases are estimated at 20,000 in 2018. The median age at diagnosis is 71 years, and the estimated death in 2016 is around the quarter of the number of the case diagnosed. 40% of patients diagnosed with CLL receive active treatment. It means that not all patients will be treated at diagnosed, and the treatment is indicated at some time during the course of the disease. We'll talk later when the treatment is indicated. Only 23% of treated patients are older than 80 years. The prevalence of relapsed refractory in patients with CLL is 17.3%. As a conclusion, CLL is an indolent disease affecting over 100,000 patients in the US and causing nearly 5,000 deaths each year. Chronic lymphocytic leukemia is a slow progressing cancer in which mature clone B lymphocytes accumulate in the bone marrow, blood, and other lymphoid tissue. The accumulation of those lymphocytes leads to leukocytosis, lymphadenopathy, and hepatosplenomegaly, bone marrow failure, and recurrent infection and autoimmune disease, especially hemolytic anemia. CLL makes up over 32% of all leukemia diagnosed in adults. It's the most frequent leukemia in adults. 5-year survival rate for people with CLL is 84%, and 89% of the patients with CLL have other comorbidities at diagnosis. It is important why we are mentioning this, because it has an important impact on the choice of the treatment and on the treatment itself and on the objective of the treatment, as we will see later on. Average age of diagnosis at diagnosis is 70 years, as I mentioned before. From a clinical overview, those mature lymphocytes will accumulate in the bone marrow and other compartments, lymph node, liver, spleen, and will lead to anemia, fever, or excessive bleeding. Early CLL is often asymptomatic, and many patients clonal lymphocytosis in elderly people with unknown significance. If we do immunophenotyping randomly for elderly people more than 80 years, we can find 3 to 4% of those persons with monoclonal lymphocytosis, but without any clinical significance. CLL is a slow advancing cancer, and more than 80% of patients survive longer than 5 years, leading to a median age at death of 80 years of age. Percentage of patients surviving 5 years is 83%, and this graphic shows you the age at diagnosis. I would like to highlight that this leukemia is almost not existing in very young people, less than 20 years. There is no CLL diagnosed at the less than 20 years. The risk of mortality from CLL increases with age, although 5-year survival rates are high from the time of initial treatment. In its early stage, CLL is often an asymptomatic disease and does not require treatment. Any one of the indicators below can signal the need for beginning treatment. First one, constitutional symptoms such as fatigue, night sweats, weight loss, fever without infection, end organ function, bulky disease, huge spleen, centimeters, lymphocyte doubling time less than 6 months, progressive anemia, and thrombocytopenia less than 100,000 per microliter. Other indication to treat autoimmune complication, recurrent infections more than 3 to 4 episodes per year, and symptoms of Richter transformation, which is rapid increasing in white blood count or rapid increase or in lymph nodes, and presence of pro-lymphocytes in high number in peripheral blood. There is no known cure for CLL, and eventually most patients will progress to needing treatment. The goal of treatment has historically been to keep the disease in remission for as long as possible. The diagnostic workup for CLL, of course, physical exam, which can show lymph node, organomegaly, etc. Complete blood count with differential, which shows a lymphocytosis. Immunophenotyping and flow cytometry confirm the monoclonality of this lymphocytose and the phenotype of this specific phenotype of this clone. We will see this in the next slide. And the bone marrow aspiration and or biopsy, it can help us to show the infiltration of the bone marrow and the type of the infiltration, if it is diffuse or nodular. When it is diffuse, it's a bad prognosis. The nodular infiltration is better than the diffuse infiltration. This slide to show you the flow cytometry and the typical CLL immunophenotype. CLL requires presence of monoclonal B lymphocyte more than 5,000 per microliter, and the monoclonality is identified through light chain restriction, which means that those lymphocytes may express kappa or lambda. Characteristics cell markers, surface immunoglobulin, CD5, CD19, CD20, CD23. Those are the 5 cluster of differentiation which are accepted for a definitive diagnosis for CLL. Then it is the kind of the expression of the reaction between the antibody and the anti-antibody. Immunophenotyping helps to differentiate CLL from other leukemia and lymphoma based on specific cell markers. Other lymphoproliferative disease, such as hairy cell leukemia or mantle cell leukemia, lymphoma, etc. The staging of the disease depends on several parameters: the lymphocytosis, the organomegaly, the bulk of the disease, which means, and the impact of the disease on the blood count. There is 2 types of staging, RAI and BINET. RAI staging describes 5 stages. Stage 0 is about a lymphocytosis in blood more than 15,000 per microliter and more than 40% lymphocytes in the bone marrow. The primary strategy is to watch and wait, and the percentage of diagnosis is 28%, and those patients have the best survival, which with a median of 150 months. The stage 1, it's stage 0 plus enlarged lymph node. The treatment also is not indicated in this stage, and the percentage of those patients at diagnosis is 44%, and risk status is with a median overall survival between 71 and 100 months. There is what we call stage 2 with splenomegaly, hepatomegaly, or both. The same, those patients represent 14% of the patient at diagnosis. The stage 3, when there is, in addition to the characteristics developed before, anemia with an hemoglobin level less than 11 gram per deciliter or hematocrit less than 33, and the stage 4 when there is thrombocytopenia with a platelet count less than 100,000 per microliter. In the stage 3 and 4, the majority of the patients are treated, the treatment is indicated, and their percentage at diagnosis of this stage is around 14%. Unfortunately, the risk status is high to median overall survival is 19 months. The Binet staging is less complicated, A, B, C. A, when there is a confirmation of the diagnosis of CLL, of course, with hemoglobin level more than 10 and the platelet more than 100, it doesn't take into consideration the lymphocytosis or the importance of the disease in the organ. Yes, it takes it less than 3 enlarged area, but it takes less than it takes the organomegaly little bit less into consideration than the race staging. The stage B, when hemoglobin more than 10 and the platelet more than 100 and more than 3 enlarged area, and this Binet C, when hemoglobin less than 10 and or platelet less than 100 and any number of enlarged area. Patients who are staged with low or low intermediate risk disease can be observed until evidence of active disease. The treatment of CLL, when the treatment is indicated, we have to know that it's a chronic disease. We cannot cure this disease, and the treatment is given to obtain a remission for the longest duration, the longest remission possible. It is the main of the treatment. And the disease, when the disease recurs, the treatment became more difficult and the duration of the remission is shorter. The duration of response and progression-free survival decrease while the risk of complication increases with every successive line of treatment. It is why we are happy to have a new generation of treatment. We are obtaining this unmet need with those treatments. The factors associated with poor prognosis, the most important is the previous treatment. As I said before, look at those two curves. The first one at left show you that when the treatment is given in first line, only 25% relapse with FCR at 2 years. Only 25% of the patients show a relapse at 2 years. But when the treatment is given as a second-line treatment and at relapse, at 2 years, we observe more than 50% of the patients with the same regimen. The factors associated with poor prognosis, actually, those are highlighted in red. Bien sûr, of course, advanced disease stage, Ray and Binet stage C, Ray stage 3 or 4 are both a bad poor prognostic factor, but the most important is IGHV gene, immunoglobulin heavy variable gene. The form unmutated are bad. The form mutated have a better prognosis. The expression of some proteins, LAP70 and CD49, are less used because the IGHV gene, the status of this gene gained more and more importance in the
We apologize. We have to go to go to the second presentation. The second presentation will be done by Professor Joseph Attan. So we'll talk about evolving therapy in CLL. So Joseph, please. فيك تبلش جوزيف؟
Yes.
ما عندك problem بالconnection?
No, good evening. I hope that I will not have any problem. My connection is very good. And I'm now sharing my slides.
Okay. Yes.
It's okay?
So, yes.
Now, thank you, Ahmad, for the introduction. Thank you, Fadi Farhat, for this activity, for this continuous program of activity and education. And I will talk about the treatment evolution of CLL. In fact, as Nizar said, that he was very pleased or very happy to have new drugs, new target therapy, new concept in treatment, and a real evolution in the treatment of this disease. So in the first slide, I will summarize the evolution or the progression of the treatment concept of the disease. We remember during my years of residency that the only approved therapy was the chlorambucil, an old alkylating agent, and cyclophosphamide, and the focus at that time was the palliative care. So we consider that these patients are very elderly, and it's primum not to cause harm to these patients. Then the chemotherapy was progressed, and we got a new or more drugs like the purine analog. The combination of fludarabine and chlorambucil allowed better response rate. So we looked at the time to the response rate of CLL. Then we discovered the new molecules, the targeted therapy, and the monoclonal antibodies targeting CD20 or like rituximab, then alemtuzumab, ofatumumab, obinutuzumab. There was the combination of the chemoimmunotherapy, which had a success starting in 1990, and lately we have a free chemotherapy combination therapy based only on targeted therapy, like ibrutinib, BTK inhibitor, or BCL2 inhibitor, the venetoclax. So in 2010 to 2020, we were looking more for long-term outcome, better PFS, and better overall survival. So the aims or the goal of CLL therapy is no more to get stable disease, neither to get partial response or complete response. The ultimate goal is to get the MRD negativity. Now we can look to the remnant, to have less than one cell of CLL cells circulating either in blood or bone marrow by performing a specific flow cytometry or real-time PCR, and to achieve a zero MRD. This slide showed the importance nowadays to get a very low MRD, negative MRD, hoping to get cure in these patients. So facing a patient with CLL nowadays, we have to decide which the best approach suit this patient. And what we are looking now is to devise patients in FIT based on the ECOG performance status, clearance of creatinine, the CIRS as defined by the ASH, the cumulative illness rating score, CIRS, less than 6, the age less than 65 years. So these patients are with good performance status, and these patients can be treated with intensive therapy with the aim to have the deepest MRD and to hope cure. And in the opposite, we have the elderly patients with comorbidity, CIS score high, low performance status, renal impairment. These patients at the right of the screen are the frail patients who will still benefit only from palliative care. And in the middle, we have between the fit and the frail, the unfit patient. Well, we plan less intensive therapy aiming to control symptoms. Here we have some kind of algorithm with the recommendation of first-line combination therapy. If we look to the first horizontal line, here we have almost 65 to 70% of our asymptomatic patients with inactive disease. We do not have to forget that these patients are only followed. We practice what we call the wait and see. And when the disease became active, so we have to look to the most important prognostic factor is the deletion 17 or P53 mutation. If we have this mutation, the most used drug is the ibrutinib, or we have other combination if the ibrutinib is contraindicated. And if we don't have the deletion is almost 14%, something like this. In the majority of cases, if we don't have the deletion of 17, we are looking to the mutation of IGHV mutation in a fit patient. We go directly to the chemotherapy to FCR. If we have patients who don't have deletion 17, who are fit or unfit, and EGHV mutated or unmutated, so we have the other alternatives, ibrutinib, venetoclax, obinutuzumab, chlorambucil, obinutuzumab. So we have a lot of combination to use in first line. And now I will start with the chemoimmunotherapy. We are going back to the 1990, and we will look to the success of this combination at that time. And we will focus on FCR, which remained indicated in some patients nowadays. So the first study, it's the CLL8. It compared the FC at the time, the combination of chemotherapy, Fludara and cyclophosphamide, compared to the CIT, chemoimmunotherapy, the FCR, 6 cycles per hour. There was 817 patients randomized, and the eligibility criteria were open, and we will look to the PFS as primary endpoint and overall survival at secondary endpoint in the second slide. Here we have a evident difference in favor of the chemoimmunotherapy, in favor of FCR compared to FC. We have a median PFS of 56.8 months with FCR compared to 32.9 months of FC. And if we look to the right of the screen, we have the overall survival showing a tremendous difference between the FCR and the FC. Median overall survival of the combination immunochemotherapy was not reached, while the FC is 86 months. Are you following? Can I have an answer?
Yes, we are following.
So we will move to the CLL10. The CLL10, it's almost a comparison between the two chemoimmunotherapy. The FCR were proved efficacious, and there was another alternative, a competitor combination, which is the bendamustine rituximab, the BR. There was a study, the CLL10, which randomized 564 patients between FCR and BR for 6 cycles. And in the inclusion criteria, patients were not allowed to have deletion 17. Yani a patient with deletion 17 were excluded. And the primary endpoint was PFS, secondary endpoint overall survival. And here we have the the advantage or the superiority of FCR compared to BR in terms of PFS. To the left, the slide, the curves show that the median PFS of FCR was 55.2 compared to 40.7 months with BR, and the p-value was positive 0.003. However, to the right, there was no difference in overall survival. And since the design of the study was some kind of non-inferiority BR compared to FCR, so the difference without any difference in overall survival, the conclusion was more in favor of the equivalence of the two drugs. However, if we look to the toxicity, despite a higher FCR PFS, the toxicity of FCR was higher. Neutropenia was 85% compared to 59% in the BR. Infection 38 compared to 24. And at the bottom of the table, the discontinuation due to adverse event was higher in FCR, 23 versus 13. So FCR showed same overall survival, better PFS, maybe higher toxicity, but there is a stable room for this combination in the current treatment of CLL. Patients who are young, who have a IGHV mutated without deletion of 17 will have a better outcome when they are treated by the combination immunochemotherapy FCR. So it's based on a sub-analysis of CL88, a phase 3 study in the middle, also based on the MDACC phase 2 study and in an Italian retrospective analysis. Also in the combination immunochemotherapy, another study called CLL11, it is a 3-arm randomization study, but we have to focus only on 2 arms, the first and the third. So it's the combination of chlorambucil plus obinutuzumab in the first arm compared to chlorambucil rituximab. So we have the same chemotherapy, chlorambucil, either with rituximab or obinutuzumab. And these patients are some kind of unfit patient because according to the inclusion criteria, the CIRS more than 6 and the creatinine clearance less than 70. And the primary endpoint was PFS as well as secondary endpoint overall survival. So as expected, the chlorambucil was with obinutuzumab was better than chlorambucil with rituximab in terms of PFS and also in terms of overall survival. To the left, we can see that the median of PFS of obinutuzumab chlorambucil 28 months compared to rituximab chlorambucil 15.7 months. And for the overall survival, also the difference was significant. The chlorambucil obinutuzumab was not reached as median, and the rituximab chlorambucil was 73.1 months. Let's move now to the more recent drugs, the more attractive combination, free chemotherapy combination, the targeted therapy. And I will start with the RESONATE-2. The RESONATE-2, it's a pure comparison between ibrutinib and chlorambucil. 269 CLL patients randomized 1-to-1. But according to the inclusion criteria, these patients are elderly, more than 65, and they do not have the deletion 17. The primary endpoint was PFS as assessed by independent review committee. The PFS at 1.5 years at the left of the screen showed a better median PFS with ibrutinib, not reached, compared to chlorambucil 15 months. So it's obvious ibrutinib is better even in elderly patients. And if we look to the left, we have the PFS with a longer follow-up, 5 years. Also, the difference is significant. PFS median not reached with ibrutinib and 15 months with chlorambucil. Let's move to the Illuminate. Illuminate study, it compares almost the same things, ibrutinib versus chlorambucil, but this time with obinutuzumab in each arm. So it's a combination ibrutinib, obinutuzumab versus chlorambucil, obinutuzumab. And there is, the patients received 6 cycles, randomized 1-to-1, starting from 229 patients. And these patients as inclusion criteria are really frail. That means either they are more than 65, or if they were younger than 65, that means they have to get one of the poor risk factor, that means CRS more than 6, or creatinine clearance less than 70, or deletion 17, or TP53 mutation. The primary endpoint was PFS. PFS was assessed by an independent review committee to the left, or by investigation to the right. In both assessments, the difference was in favor of IO, ibrutinib and obinutuzumab compared to obinutuzumab chlorambucil. The difference was significant, P less than 0.0001, and in both assessments. Here it's a slide, not very clear, but it's a slide that I brought from the E25, a few months studies comparing targeted therapy, only targeted free chemotherapy regimen versus chemoimmunotherapy. We have the Illuminate, what we saw. We have the Alliance, IR versus BR, ibrutinib rituximab versus bendamustine rituximab, or the venetoclax obinutuzumab versus chlorambucil obinutuzumab. Or two are superior.
Doctor,
Are you hearing me?
You have to share your screen again, please.
Okay. Okay. It's my last slide. I have a small conclusion here. Are you seeing the slide? Once again, there's two ideas to share. Targeted therapies, BTK inhibitor or venetoclax-based regimens are superior to chemoimmunotherapy in the frontline and in relapsed refractory setting. Yet, frontline chemoimmunotherapy, FCR, is still an option for fit patients with mutated IGHV with no TP53 aberration. And thank you for your attention. It's not.
Thank you.
Okay.
You are hearing me?
I finished with that.
Thank you, Joseph. We have a problem of connection. Fadi?
No, it's okay. Joseph, you are
We have a problem, correct. Okay. Thank you, Joseph, for your presentation. So we have a few minutes for questions, and we can debate, we can discuss a lot of things in the treatment of CLL in first line or refractory relapse. So, someone have a question? Or
what are the patients, if I may ask a question, are you still treating patients with FCR? I have seen your algorithm that super fit, like Superman.
Absolutely. According to the sub-analysis of FCR, the conditions are patients who are fit. Fit, that means less than 65, unless we have a performance status, a chronologic age or physiologic age younger. No, these patients have to be young. They have to be a mutation at the level of AGHV, and they have not to have a deletion 17. So these are the category of patients that can benefit from chemotherapy, between brackets, from chemoimmunotherapy.
Dr. Ibrahim, can we hear your comments?
Yeah, I think...
But you are chairman,
Yeah, but I am...
You remember.
Exactly. I understand, and you asked. So the question is very important. Is FCR still alive or is dying? This is what Dr. Marwan would like to ask you clearly. Sheikh Marwan, FCR
yes.
is a good treatment for fit patient, super fit patient without bad prognostic factors. But if we see now the randomized study, ibrutinib R versus FCR, in terms of PFS, ibrutinib R is superior to FCR. The survival is not different, clearly different, significantly different, but the PFS is higher. The problem of FCR is the toxicity, and if we can shorten FCR or add something to FCR and shorten FCR, it could be probably better, because the IFCG that the MD Anderson used and they still continue to use to treat even mutated immunoglobulin, you have almost 100% survival with shorter and limited number of chemotherapy. So FCR is still alive, less and less alive, I think. So we have to put FCR probably for the super fit patient without any prognostic factor. But probably in the near future, with these new drugs, we will use more and more targeted therapy, and targeted therapy PO or something applicable easily to chemotherapy. It will be more useful than chemotherapy. Now, I have a question, Joseph. Maybe you didn't have sufficient time to elaborate more and more therapies and new combinations. It was a little bit short for venetoclax. If you have the possibility to have...
Dr. Ibrahim, that's just one there is a part for the venetoclax. That's why he didn't develop also.
We still have venetoclax and to keep the best for Colette.
Colette.
Who can ibrutinib most probably.
I was saying, no, that's why he stopped.
Yeah.
تركنا شافي for the follow-up session.
But this also, I would like to ask a question to Colette and to Joseph. If you have a patient for target therapy, and the patient we could use ibrutinib or venetoclax, what do you choose a first-line therapy for this patient? In a combination of immuno.
It's better to keep the answer to these questions at the end, after the presentation of Colette on venetoclax.
So, بدك تقبل الآخر نسألك يعني معها.
Hey, I'm ready to stay. because in my presentation I avoid to talk about venetoclax, keeping the cream to
yes,
the
yes.
end.
Okay, understand. I kept the message. I think that the question of Marwan was very important. And I would like to ask Marwan, do you continue to use FCR as before or much less than before? Marwan, am اسمعنا? No.
Wait, the
Marwan,
voice is a
unmute
little
yourself.
Dr. Ibrahim, I didn't hear you.
Hey, Dr. Marwan, your question was a very important one. Like a little bit provocative for something. So, do you yourself using FCR less than before, much less than before, and switching to to target therapy?
Of course, as much as I can.
As you can.
We are very limited, but as much as we can, we are trying to develop the algorithm that Dr. Khattan have showed you according to the fit, unfit patients, mutation, not mutation. We are trying as much as we can to follow up this particular algorithm. And I think that Dr. Colette will elaborate more on this algorithm also.
Okay, so it will be probably interesting to keep the question and debate at the end of the session. So I can now
there is a question a basic question from Dr. Haifa Kulaylat asking if myelodysplasia lead to CLL and are they related? I don't know if you want to address this question now, Dr. Ibrahim, or to keep it till the end.
Maybe we can keep this at the end. This is we probably we keep the question for the end. We can debate many things, and I think it's better to handle the second session. And
there is still a part of the presentation of Dr. Bitar if he wants to continue it.
I don't know if Nizar Bitar is still with us or no.
He is with us. I see him. I see his nice face in front of us.
If Nizar is here, so Nizar will continue. Okay.
Like, I apologize لأنه كفيت I continued my speech thinking that I am online, but I was not online at the end.
So this was a placebo presentation for us, but for you an active one.
Yes, a placebo presentation, yes. But now I am using my iPhone to hear you and to communicate with you. Because when I use my laptop, the connection will be lost. أنا كان عندي بعد 2 slides.
Okay, continue. اعملهم.
لا ما عنديش لكن 2 slides. There is one important slide with the indication of the treatment of CLL. But I am unable to open the presentation on the iPhone.
Yes, you can tell them, you can tell us orally, heck, if you want, 1 minute. CLL must be treated one and
I will
one.
develop. When there is indication, the most important indication for beginning the treatment of CLL is when the patient is, first of all, rapidly progressing, which means that the doubling time of lymphocyte is less than 6 months, or rapid increasing in the volume of the spleen or of the lymphadenopathy, and they became unbearable by the patient, and there is indication to treat at this moment. The second, when we have one of the constitutional symptoms of the CLL, I mean fever or night sweat or weight loss, unexplained weight loss, etc., or recurrent infection more than 3 to 4 episodes per year, or autoimmune hemolytic anemia or autoimmune thrombocytopenia, which cannot be controlled by steroid alone. I think, or the presence of unexplained fatigue or unexplained fever more than 38 in the absence of any infection, etc. And when the disease progresses in its stage 4, or in C stage, which means that there is thrombocytopenia and or anemia. In this case, there is indication for treatment. And the choice of the treatment will be based, as Dr. Qattan explained, well, on the molecular, on the molecular and on characteristics of the disease. I mean the immunoglobulin heavy variable chain status, and the cytogenetic study and molecular study, especially the aberration, the presence or absence of P53 aberration, which means P53 mutation or 70p deletion. And the choice of the treatment also can be based on the associated comorbidities the patient can, and his age or the other condition associated to the accompanying the disease, existing at the same time. Those are taking all those into consideration. I let you the choice of the treatment accordingly. Thank you for your attention, and I apologize for the bad connection in Beirut for the internet.
Thank you, Dr. Nizar. So I think that we have to move to the second session. The chair is the chair is.
Maybe Ahmed, I can add also something which will be debated later on. The choice of the treatment also depend on the availability of the drug and the reachability of the drug by the patient or by Heidi. It's very, very important.
This is another problem. If you don't have cortisone, you cannot treat even CLL. So
but we have sometimes we have difficult access to treatment.
Shortage or limited access or sometimes difficulties. Yes, we know.
Yeah, okay.
We are not US or Europe or Western Europe. So now Professor Marwan Ghosn will share the second session, and I think the debate will be interesting at the end of the session.
Thank you, Ahmed.
You are welcome. Thank you. Marwan.
Thank you very much, everybody. Thank you very much, Professor Ibrahim. Thank you very much, Nizar also. And first of all, I would like to thank our friend and colleague Fadi Farhat for his continuous enthusiasm in pushing these ABC. We are currently in oncology. We are currently waiting for them on a weekly basis. And it gives us also the opportunity to meet together, even if it is only virtually, and to enjoy also the science. Let's move to the second part of this very interesting symposium. And I have the pleasure to introduce also Dr. Colette Hanna, who is head of hematology oncology at St. Joseph University Hospital. And she have the task to develop a topic entitled "How are we moving to a new era?" and to develop and to discuss the role of Venclexta. Please, Colette, the floor is yours.
We thank you. I want to share my presentation. So thank you, Dr. Farhat, thank you, Dr. Ghosn, thank you, Dr. Bitar, thank you all for all the participants for a very nice symposium. And I'm going to talk about now Venclexta approved indication in CLL and small lymphocytic lymphoma. So as we all know, the mechanism of action is very clear. In fact, we know that the BCL2 family of proteins regulates the apoptosis. So it regulates the apoptotic process, and it consists of the balance between pro-death and pro-survival proteins that will regulate, in fact, the apoptosis and the natural death of the cells. So the BCL2 protein is a pro-survival protein, and it can promote cell survival. So if we have an imbalance between the dynamic between the BCL2 protein and the other proteins that are pro-DES proteins like BAX, BAC, BIM, or BEAD, we will have, in fact, blocking of the cell death and an activation of the tumoral cells. So venetoclax is very simply, in fact, a BCL2 inhibitor, and it will rebalance, in fact, the problem between the proteins, between the pro-DES proteins and the pro-cell survival proteins. So, and venetoclax will induce the cell death irrespective of TP53 function, as the effects of, in fact, BCL2 inhibition are thought to be independent of this pathway. Second thing, it's an orally available small molecule, and it will restore in that way the apoptosis and the balance we talked before. So the first pivotal trial that was done with Venclexta was the Murano. And the Murano data, it was in relapsed refractory patients. It was a phase 3 open label randomized study in patients with relapsed refractory CLL to evaluate the benefit of venetoclax rituximab compared with bendamustine plus rituximab. So it was a 1-to-1 randomization. We had a subgroup with a deletion 17p. It included 400 patients, and it was divided in 2 groups. The first group received rituximab for 6 cycles along with venetoclax 400 milligram PO daily. Do not forget to ramp up the venetoclax in the cycle 1 to avoid any tumor lysis syndrome, versus BR, bendamustine plus rituximab, 6 cycles, which was a standard of care at that time. If we look at the 2 subgroups, the 2 subgroups were very similar, with a median age of 64 or 66 years, with the lymphocyte count that was balanced. Also, the T53 mutational status was the same in the 2 subgroups, along with the deletion 17p, and the IGHV mutational status, unmutated, mutated, or unknown, were the same. Interestingly enough, also the number of prior therapies were also the same in the different subgroups. And the last thing to say that in the 2 subgroups, we have fludarabine refractory patients at the same time. The PFS is talking by itself here. We see that the 2 curves are really separated. And in the last ASCO 2020, also it's still separated. Venetoclax plus rituximab versus BR, the PFS is really different between the 2, and the curves are very clear about it. So at 2-year estimate, we have 84% of the patients that were treated with venetoclax and rituximab who were free of disease versus 36% in the BR arm. At 3 years, it was 71% versus 15%. So really, these are numbers that we don't see very frequently in hematology or in oncology. And it seems that venetoclax rituximab here had a very good PFS. And if we continue at 4-year estimates, we have also the difference with 57% of the patients still in remission versus 4% in the BR arm. The second study that we have to talk about, it's Venclexta in previously untreated CLL patients, the CLL 14 data. It was also, in fact, randomized trial with previously untreated CLL with coexisting conditions. Why this is important to say with coexisting conditions? Because we had 2 arms, the venetoclax for 12 cycles with obinutuzumab for 6 cycles versus obinutuzumab and chlorambucil, which was the standard of care at that time for elderly patients or patients with coexisting conditions. That's why the arm of chlorambucil obinutuzumab was selected for this trial. It was a 1-to-1 randomization, and the total CIRS score, which is the score that we use for elderly in CLL now, was superior to 6 in every patient, and the creatinine clearance was inferior to 70 milliliter per minute. So it's a 1 year, in fact, treatment for this study. As usual, for the patient's characteristic, the two subgroups are very balanced. We have an equilibrium between the stage, the tumor lesions syndrome risk category, the total SIRS score, the deletion 17p, and for the other subgroups like the TP53 mutation or the IGHV mutation status. The primary analysis, we see that venetoclax plus obinutuzumab was really more efficient than the Gazyva plus chlorambucil. And as we see at 24 months, 88% of patients receiving venetoclax plus obinutuzumab had not progressed or died versus 64% with the chlorambucil and obinutuzumab. For the response rate, also we see that 85% of the patients with venetoclax and obinutuzumab had overall response rate versus 71%, and we had a complete response in 50% of the patients with the combination of venetoclax and obinutuzumab. What about the minimum MRD data, in fact? Like Dr. Attan said, it's more and more important now to talk about minimal residual disease because minimal residual disease can be a biomarker for our treatment, and maybe we are beginning to see some cure in the CLL patients. So if we see the MRD data from Murano trial, we had undetectable MRD in the peripheral blood in more than 50% of the patient versus 12% of the patient. This is really spectacular and excellent. And why is it important? Because if you look at this slide, which is a little bit complicated, but at the end of treatment, after 24 months, we see that the patients that achieve MRD will have very little chance to progress afterwards. It will take them years to progress versus the one that will have detectable MRD. Also, the MRD data from CLL14 trial, we had 76% of patients having undetectable MRD versus 35% in Gazyva plus chlorambucil arm. And this also was very important. The MRD, you can do it, in fact, on the peripheral blood, but of course, also it can be done, and it's better to be done also by flow cytometry in the peripheral blood, but also it was done also by PCR in other centers. So minimal residual disease is predictive of PSS with chemoimmunotherapy in CLL, and we know that not only from the Murano trial or from the CLL14 trial, but we know that also from the previous trial like CLL8, CLL10, and CLL11. And the more we have undetectable MRD at the end of treatment in the chemoimmunotherapy, it was highly predictive of prolonged PFS. What about the safety data with Venclexta and rituximab? So it was very manageable with neutropenia, some diarrhea, infections and infestations, some muscular and connective tissue disorders, and some nutrition disorders. But since we used to treat all our patients with CLL with FCR, it was, I think, easy to handle versus, in fact, the chemoimmunotherapy. We didn't have any more grade 5 events or grade 3 or 4 events than with the other arms. So as you see, in fact, fewer even safety events were observed during venetoclax monotherapy after the combination treatment period when we didn't have the Gazyva anymore with the treatment. Subgroup analysis, this is important also that Venclexta and in fact it works in every subgroup. Also, it works in the deletion 17p, as you see, in fact, in this subgroup. It's in favor of the venetoclax and rituximab. It works in IGHV mutated or unmutated. So all the subgroups are favored when we use venetoclax plus rituximab. Another interesting also analysis from the subgroup is that with the IGHV mutational status, whether it is mutated or unmutated, even in the mutated group, we see that we have a very good response, like in fact the chemoimmunotherapy. So if you have comorbidities, really all the subgroups can benefit from this combination. Dosing schedules, I think we know now how to ramp up the Venclexta or the venetoclax. So we ramp up because of the tumor lysis syndrome. In fact, it's so potent, the drug is so potent that we have really to ramp it up slowly to avoid any TLS. So we begin the onboarding with 20 milligram, then we go to 50, 100, 200, and when we reach our final dose, which is 400 milligram. The rituximab dosing, in the cycle 1, you will use 375 milligram per square meter. But as we know in CLL, afterwards, you have to increase to 500 milligram per square meter by cycle. The venetoclax plus the Gazyva, it works in the same way. We will have also the ramp-up period, 20, 50, 100, 200, 400. And the Gazyva, as you know, you have to split, in fact, the Gazyva the first time in follicular, but not in the CLL. You could give 1,000 milligram. And if you want to split, you can give the day one only 100 milligram to see if everything is fine, and you give the 900 milligram on day 2. So what is an optimal CLL treatment today? And that was Dr. Brahim wanted to discuss, and I think all the panelists and all the participants wanted to discuss. So should it be oral? Is it good for the patient that the treatment will be only oral? Should it be chemotherapy free? Should we aim to achieve a disease-free or to achieve an MRD and deep response? Should it be given through a fixed period of time? Should we also take care of the toxicity, the tolerance, the cost effectiveness also? And of course, it must be accessible to patients. So if we see, in fact, for the traditional chemoimmunotherapy, it's often associated with potential safety concern, since we know that it will have immunosuppression. We can have also secondary hematologic malignancy, especially with fludarabine, with AML, myelodysplastic syndrome, and Richter transformation. This does not mean that we don't have secondary malignancies with the other treatments. We have them, but it's more it's not as proven as in the chemoimmunotherapy arm, and we have a high risk of other cancer. With Venclexta, there is a need for a treatment, of course. It allows a tolerable safety profile. It offers a deep remission with a minimal residual disease that is also, in fact, undetectable for more than 50 and even 70% of the patient. And it is a fixed treatment, so it can help us also for our third-party payers. The targeted therapies often don't lead us to an undetectable MRD, and it should be given until progression. And also for the targeted therapies that we know, we have some concerns for certain toxicities like cardiac toxicities like atrial fibrillation or bruising or anticoagulation. So if we want to go back to, in fact, like a diagram, and we can discuss it, in fact, if we want to see the first line CLL, we have always to divide our patient into fit or unfit patient. If they are fit, they could be fit and 70 years old. We all agree on the physiological age. So if they are fit and they have a mutated IgHV and non-17p, we have to give the chemoimmunotherapy, because we know that we have a percentage of patients that will be cured with the chemoimmunotherapy. And when you will give the chemoimmunotherapy, please let us try to give it at the dosage of the protocol, in order, in fact, to have the cure that we hope in this specific subgroup of patients. For all the other subgroups, unmutated IgHV or the 17p, you have to use targeted therapies. If they are unfit and you cannot use chemoimmunotherapy, whatever the status, you will have to use, in fact, targeted therapy. For the relapse refractory, also here, if they are unfit, you will switch from a targeted therapy to another, since now we have more than one targeted therapy. And if they are fit and they have non-17p, you can re-challenge if you want. If you don't want to go straight away to targeted therapy, you could re-challenge with chemoimmunotherapy. It's still in the guidelines. So from the reimbursement body perspective, of course, when they want to evaluate an approval of a drug, they want to see the efficacy of the drug, of course. They want to have a pharmacovigilance to make sure that we don't have adverse events, and to make sure that we don't have, after the post-marketing, in fact, and the treatments on our field, some side effects that we didn't have during our randomized trial. And the economic value is very important. And I thank you, and I'm ready for any question if you have any question for me.
Thank you very much. Thank you very much, Dr. Hanna, for this very elegant presentation. We will take some questions now. It's only few questions because of the clinical value of it, and then we'll go to a general discussion at the end. Practically, do you have any issues in performing the mutations evaluation, the IGHV evaluation? Can you tell us practically, because a lot of physicians, I think, and patients fears this practical point of getting to the mutations and the IGHV evaluation. Tell me a little bit practically how it is.
Practically, Nana, we are doing the IGHV mutation at the Faculty of Medicine, and it's done for free, practically. So I think it's easy to be done.
Is it supported? Is it supported? This is why it's done by free?
It is supported. It is supported.
By
another company.
By another company?
Yes, the IGHV mutation is supported at Faculty of Medicine by another company, but I don't. I think AbbVie probably supports it in a.
I can confirm it. I can confirm that as we are sponsored by AbbVie, we cannot let you say it without giving the comment. It's only for the being equilibrated. It is supported in other labs. The FISH test is supported in other labs for the IGHV also by AbbVie. But let's go.
17p is supported by AbbVie also in everywhere practically, and in the Faculty of Medicine it was only about the IGHV. In fact.
Okay, so practically we are supported, so the patient doesn't have this issue on doing the IGHV. Okay, and how much does it take? The time wait for these mutations and
practically we have it in less than 1 week.
So in 1 week, so there is no issues of letting wait your patients for that.
No, 1 week to 10 days we have it practically.
Let me check if we have any questions. Yes, we have a question from Dr. Isam Al-Faham in the COVID era. You know, so it's a hot topic now. We go usually for less toxic regimens, but ramping up with the venetoclax and TLS prophylaxis renders patients to stay in the hospital for the first cycle at least. So what are your insight of that?
What is interesting now is that
syndrome for the
we have a paper now saying that ibrutinib is a protective drug against corona. So this is interesting. And yes, we should avoid now hospitalization if we are in one of the periods of corona that is very important. Like now, for example, in Lebanon, we have an increase, a major increase. But yes, exactly. And we know that the anti-CD20, all the anti-CD20 can be also risk factor for the corona, for the COVID-19, since it depletes the B cell lymphocytes. So yes, in the special case of COVID-19, maybe we should go to a targeted therapy if you are fearing now the COVID-19 that will not include an anti-CD20 or it's not the ramp up or the TLS that makes me wonder about it. It's more the anti-CD20 drug that we use with the venetoclax.
So you have issues on using CD20, anti-CD20 drugs during the COVID-19 because of the depletion of the lymphocytes. So this is your own issue, not the use of the drugs per themselves. Because personally, I think tumor lysis syndrome prophylaxis, you know, it's only 1 day in the hospital. So I don't think that it is a real issue even in the COVID-19 epidemic, unless we are in a hospital where all the patients are COVID. Dr. Brahim, do you have a Dr. Brahim? I hear you. I hear you. Can you hear your comments?
Yes,
but I want to see you also.
Yes.
I want to see you also. I want to see you.
I'm here.
Yes.
So I would like to inform you that we sent the statement of the Lebanese Society of Hematology for hematological malignancies in the COVID era, and it is in reviewing with the frontier of hematology. I think it will be published next month. What Dr. Hanna said is true. For anti-CD20, it's important to avoid it or to delay it because of this huge immunosuppression induced by anti-CD20, not only for CLL, also for some other diseases needing anti-CD20. Now, for venetoclax, the issue is the patient must be admitted for a few days to avoid or to treat or to prevent TLS and to treat TLS. We have TLS, and also there is the hematological toxicity of some drugs. So if you with venetoclax, sometimes could have some hematological toxicity unexpected for some patients. So we have to be careful. It is by many societies, the American Society of Hematology, the EHA, and the ESMO. They tried if venetoclax could be. They stated that if venetoclax can be delayed, it could be better. Not avoided, but it can be delayed and then used according to the pandemic. So it was easier to use it probably 2 months ago in Lebanon, but now with the pandemic, with the increase in the pandemic in Lebanon, we have to be careful. I agree with Dr. Hanna for anti-CD20 and venetoclax. In this case, probably using other target therapy could be interesting. Then if we can move to venetoclax, it could be.
Or we could use Venclexta in monotherapy if a patient is already on ibrutinib and he progresses.
Yes, you can give it. You can give it in monotherapy. But if you see until now, if you see the studies, venetoclax were used in maintenance in monotherapy, not in kind of first-line therapy. Monotherapy is after some combination, including anti-CD20 or ibrutinib or other drugs. So
still, I think that all of us, I think we need to move, but I think that all of us have been using a lot of tailoring, personalization, adaptation of the treatment to all the patients during this COVID-19 era.
Those are the statement of many societies. So
which is important also is to say that now that AbbVie is supporting the deletions, the fish testing, the IGHV mutation. Now I think we don't have any excuse not doing all the tests to have all the information we need on our CLL patient and to choose our treatment accordingly. And not to stay and stick on our chemoimmunotherapy that we are used to give before. And as we see, the chemoimmunotherapy is becoming a smaller and smaller niche, in fact, in CLL.
Probably the only indication is the super fit patient without any bad prognostic factor when you don't have target therapy.
And the second thing that we must say. The second thing we must say also, and I think it was interesting, but because it was highlighted in ASCO 2020 again, it's that we are going back in the targeted therapies. We used to have the latest years to take the drugs until progression. Now, for the first time, we have a targeted therapy that is for fixed dose duration. Yani we are coming back to our old protocols where we have 6 cycles or 12 cycles, and then we stop. And then it's important for us from an economical point of view and for the treatment also. Because it's less burden for the patient when you tell him, okay, you will have 1 year or 2 years treatment, and then you will stop. It's a major concern for the patient.
But one important problem, like Joseph said before, this is MRD. I think now undetectable MRD or MRD evaluation is a very important point in treating patients with CLL, particularly fit patients. So,
yes. So
let's let's stop the discussion here, because we will have a second part of the presentation, which is very important, and we'll tackle these issues of time of the treatment, limitation, you know, resources, etc. So let's go, Dr. Hanna, if you want, to your second presentation.
No, we said it. It was the slide, the 3 slides. We finished. In fact, I finished.
Okay, so you ended it. You ended it. Okay, so we can continue in the discussion. I thought that you had prepared some other slides. So let's go back. So let's go back, because this point of the limitation in time, we have a certain treatment, we have a certain period of time. I need to hear your comments on that. Dr. Hanna stated it a little bit. You want to elaborate more, Dr. Hanna?
Yes, and I was saying, when we have a fixed dose duration of treatment, it can be something that the third-party payer can see as economically good for the patient and for the society also, because it's a burden. When we have a treatment that we have to take for years and years, it will be an economical burden also for us all. The second point is important, is here we have a biomarker, and we have the minimal residual disease. We know that if we achieve a minimal residual disease at the end of treatment, these patients, after 4 years, now we have a follow-up of 4 years, this patient, more than 50% of the patient did not progress after 4 years. So if we have at the end of treatment an undetectable minimal residual disease, we would have given a fixed dose duration treatment with this amount of money, and we know that we will have, in fact, more than 3 or 4 years, 50% of the patient who will not relapse. And a second thing, that we didn't have any data before of re-challenging with BTK inhibitors after venetoclax. Now we have data with that. So we have data of giving, in fact, BTK inhibitors after Venclexta, which was one of the arguments where we didn't want to give Venclexta at the first time, because we were saying, if we give them Venclexta and we have a progression, can we give? Yeah. So now we have data, and we know that BTK inhibitors work even if we have given Venclexta before. So I think Venclexta, it's a drug that can be used in all subgroups, and it has a fixed dose duration. But of course, also we have some subgroups who will benefit from having BTK inhibitor before Venclexta. This is, of course, we are not saying, but we are highlighting what could be beneficial for, in fact, this kind of drug in particular.
Thank you, Colette. We are passing to Dr. Ibrahim, but before giving him my question, can I ask the rest of the panelists to be with us? I'm re-inviting Dr. Kattan, Dr. Bitar, and of course, Dr. Farhat to be part of this nice discussion. Dr. Ibrahim, I have heard what are your comments on the fixed period? And second, you began to elaborate on the very important point of minimal residual disease. Practically, do we have minimal residual disease in Beirut? Where are we doing it? Is it reliable? And how are you managing your patients in regard of these issues?
In CLL, as you said, minimal residual disease is a big backbone. Now it's an important one to decide to fix therapy or to prolong therapy or to change therapy. Probably to change therapy during maintenance, we have to wait for. But it could be done by next generation flow cytometry multiplex. It is done in Lebanon, and you can do NGS. or if you have, for example, on PCR abnormality, one abnormality or more, you can follow up the abnormality if you cannot do the whole genomics approach. Now, which is important, that not only how to do it, is how to evaluate it, how to analyze it. We know that for the majority of the recent study, ongoing recent study, MRD is a very important point. But in previous study, it was not designed or not taken into account in the evaluation, and PFS was the major point sometimes of our survival. Now, which is important, the analysis of the importance of this MRD is it 10⁻⁶ to be considered 10⁻⁴. We are considering 10⁻⁴ as a
until now, yeah.
Until now, but probably 10⁻⁶ is probably more interesting, and we see that in recent study sometimes you arrive to 30–40% of 10⁻⁶, like when you put ibrutinib with venetoclax, when doing two target therapy. The next
it will be, I think it will be our combination for MRD.
Yeah. And next, for example, when you go to in the CLL14, you have 40% of 10⁻⁶, which is very good. And when you associate ibrutinib with venetoclax, you have more than 90%, and you have quasi PFS at 100%, quasi survival at 100%. So the next point is NGS. NGS is growing, and this is an important point. Now, between NGS and the flow, we don't know now which is NGS is a little bit more interesting, but we have flow. We start NGS, so we can do it. We have to do it for the majority of the patient. Now, the second point, if we have to do MRD in blood or in bone marrow, 2 or 3 studies, recent studies show that there is no significant difference between MRD evaluated in bone marrow or in peripheral blood. There is a little bit. It is more interesting to do it in bone marrow if we can, but the difference is not so high. So you can go by peripheral blood. I think you could visit Blood Advanced and see what Joseph Seymour and Thomas Lu published on MRD, a very important point in the venetoclax era and maintenance of MRD. It was published, I think, in January 2020. 62 patients or 60 patients were analyzed, and they analyzed well the MRD, and they compared in blood and peripheral and the bone marrow. It was similar, and they took into account the value in the area of venetoclax period therapy if the patient is refractory to FCR or refractory to anti-CD20 or with a complex karyotype. It could be something negative to obtain the deepest MRD despite the new treatment, but MRD is with venetoclax in this experience, retrospective study showed a very deep MRD, interesting MRD. And there is also another point: when you see MRD obtained with venetoclax or ibrutinib over time, you have deeper maintained MRD with venetoclax than with
Dr. Brahim, not only that, not only that, they also showed that when we have detectable MRD again, 50% of the patients who have detectable MRD, they will not have disease. No, they will not have disease progression, which was not seen before.
But in MRD is obtained between 8 and 18 months. So sometimes you have to wait more than 1 year to have MRD, deepest MRD in some patients. So it is not typical 12 months, but 8 to 18 months is in this setting, which is interesting. I repeat that when you have, we have MRD maintained even 1 year and a half after stopping venetoclax in patients, which is not bad, which is very good.
But this is MRD on blood. This is MRD on
blood or bone marrow. We have the two MRD.
Do we have a difference? Does the technique have a difference?
I told you that.
You told me and I forgot. You told me and I forgot. Please repeat. Repeat. I need to understand.
No, لا don't worry. أقول لك إنه لأنه يمكن ما سمعتني لأنه
لا ما عليه, but we need to be clear.
In the article published in Blood Advanced, the title "Undetectable Peripheral Blood MRD should be the goal of venetoclax in CLL, but attain plateaus after 24 months." This is a very important one for MRD. I think the most important with venetoclax, and there is no significant difference between peripheral blood and bone marrow in terms of MRD detected. And when you have
the technique, and in the technique, and there are differences in the technique also.
You have the two. You have NGS and you have
both are identical.
Yes. And can I say but a small comment, Dr. Bahim?
بس خليني أكمل بس شغلة صغيرة. When you have MRD negativity in peripheral blood, or in bone marrow, the difference was not significant technically, and the performance and the PFS was quasi similar in the two ways of MRD detected.
Got it.
أنا بس
دكتورة حنا.
One comment, in fact, they had 216 patients with undetectable MRD at the end of the study. And now at 4-year follow-up,
which study? Which study?
The CLL 14.
14,
yes. With venetoclax. They had 216 patients with MRD negative. And now we are at 4 years of follow-up, only 9 patients progressed. So I think we can say more safely that MRD can be a very good way to project into the future. And when we see on 216 patients, even when they lose, some of them lost their MRD, only 9 patients progressed to a second-line treatment. I think it's a good way of thinking the CLL for.
Dr. Bitar, do you have a comment on that? I'm not seeing you. Are you with us?
Yes, I am listening.
Dr. Bitar.
Yes. I agree that MRD is very important indicator for progression-free survival, and later on, as Colette said, maybe for a long-term progression-free survival, which may lead for the cure of the disease. And as Ahmad mentioned clearly, there is no difference between peripheral blood and bone marrow, and both techniques are almost equivalent. Maybe I can add the value of venetoclax in achieving MRD in higher percentage of the patient using a fixed duration of the treatment. After all, we are interested in seeing a benefit for the patient, especially for those elderly patients, frail patients who cannot support chemotherapy, who cannot support aggressive treatment, and we are happy to see those results in those patients. Yani it is really it was an unmet need in this population, in this subgroup of patients, yani in those patients. This is why I.
Dr. Kattan, Dr. Farhat, do you have any other comments on all what have been said?
I agree that MRD, it's a surrogate nowadays. Look, we have to look for it, and we have to wait some initiatives from the lab, from the companies, even to offer MRD test by NGS, because the PCR, it's well done also. But if we have some facilities or reimbursement for the MRD, and let it use it as a routine test at the end of treatment for these patients who have targeted therapy. So the problem is the availability of the test.
Or at least by flow cytometry, but with more colors than they have now.
NGS technique.
They
can send for outside with the intervention of a company, with the reimbursement of any company, and have the NGS in a few days.
This would be great.
But still many people are using new generation flow. So if you don't have NGS, you can use new generation flow awaiting flow cytometry. Yes.
Dr.
New
Farhat.
generation flow cytometry.
Fadi, Dr. Farhat.
Nothing to add, just I think it's not really clear for some of the participants, maybe for me also, the relation. You say that from blood is the same as for bone marrow,
yes,
or almost the same, similar, but does the method using the NGS flow or others will impact first? Second, we are facing the problem of MRD in Lebanon. So you say that it's done here. I don't know. To my knowledge, it's not. So let's see.
No.
Where do
No,
you
it's
do?
not.
So Ahmed,
sorry.
Dr. Ahmed said it's done here. So to my knowledge, we
the flow, yes.
The flow is done here, not the MRD by NGS. And the flow, not all the institutions have the flow of 6 to 8 colors.
Where is it done? Give us examples. Where is it done?
Basically, you need a flow cytometer with 8 colors to have a MRD like in the trials.
For example, it is done at AUB at Makas. It's done because we have 10 colors at AUB, 10 colors. So at
champion.
Other lab 10 colors. You can go.
Other than Makas and AUB, where is it done?
It's not. But Dr. Hussein, also, it's not important to also only have the machine.
Yes.
Sometimes we have the machine with the 10 colors, and they will do 2 colors. No, it's the gating. It's the gating.
Yes.
Practically, مثل ما عم بيقول دكتور فرحات.
So I have
Dr. Farhat.
Yes, please practically give us.
Practically, we are not having a very good MRD now in Lebanon. We should work on that. Practically. If we want to do بس تقول فكرتي. If we want to do a very good MRD بصير حقه السيتوماتري يعني الفلو سايتومتري بتصير حقها $1,000 لانه بدك تستعمل كيت تستعمل ال 8 colors. ما حدا عم يدفع $1,000 دونك ما حدا عم يعمل لك ال 8 colors.
Fine. So let's go هيك we will jump into it. So we are talking about the pharmacoeconomics of all these treatments. Let's talk a little bit about the pharmacoeconomics about the treatment. I like it because if you have a surrogate of response of a drug and you have a test and the test is $1,000 for example, or even $10,000, does it worth it to do it because you are stopping, for example, the treatment at one point and you are being able to give your patient free of treatment instead of continuing a treatment until, ad vitam aeternam, for example. This is number one. And number two, does this is this point important for you when you look into the accessibility and the availability of the drugs? Because all of us, we know that we have a problem in the accessibility and availability of these drugs. And I want to hear from you, are these drugs available? Have you access to these drugs? And what are the challenges that you are facing on your daily practice every day to get to these drugs? All of you. I want a comment from all of you. Yes, Dr. Bita.
Yes, Marwan, can I give you my opinion?
Yes, of course. We want your opinion.
When we have a new drug, sometimes the payer need some time to be sure of the effectiveness of the drug, because as you know, when the drug show efficacy, it doesn't mean that when the drug is released in the market, it will have the same. We will have the same result as the result obtained in the clinical trial. And there is a lot of example on this. It is why the payer want to give the best benefit for the patient. You can be sure of this. But we are sure also that there are a lot of drugs which do not prove their effectiveness even they proved their efficacy in the clinical trial. This is even in the richest country in the world, the drug will be available sometime 2 or 3 years after its approval, or after it has been proved efficient in clinical trial. This is first. Second, it is not a matter of the cost of the drug, the price of the drug. It's a matter of the cost. The cost, what it mean? It means that the price of the drug and the other expenses we pay to cover, let's say, toxicity, hospitalization, side effect, etc. Yani now especially when the drug is active and can be done in a clear way. Yani those are the characteristics the payer look for to approve or to pay a drug. This is my opinion. In this case, in this specific case, we are faced a smart drug. We are faced a targeted therapy, a very, very smart drug. You know, in the past, we treated CLL. Yani, we have alkylating agents, and later on we had purine analog, and then monoclonal antibodies, and we never reached the results we have now. This is why it's very important. We are witnessing a breakthrough in the treatment of this disease. First, in the comprehension of the pathogenesis of the disease, and second, in developing a drug targeting the pathogenesis of the disease. It's really, it was really a dream to get this generation of drugs in this specific disease.
Are you getting? Because one second, Dr. Farhat. One second. Let 1 second. Let Dr. Bitar ends his point and we'll go. Dr. Bitar, are you getting to these drugs nowadays? Do you have the access to them? I understood the rationale of the pharmacoeconomics on how the drugs are evaluated, but are you getting them? Yes or no?
Yes, we are working on it to get it.
Okay, fine. Thank you very much.
Yes,
Dr. Ahmad.
I can do
AMAAC, I would like to add.
Let Dr. Bitar add. Yes, Dr. Bitar.
And take care in this area, in this time now, COVID. It's very important to take attention on the dose of drugs, because if we don't, especially in palliative care, in palliative treatment, when the objective of the treatment is palliative, we have to remember that the efficacy of the drug is related to the dosage of the drug. And if we don't be able to give full dose, the active dose, to the patient, really, I suggest not to treat the patient with cytotoxic drugs. Someone asked about the era of COVID, what to do. In oncology, not in hematology only, if we are not able to give the active dose and the efficient dose, I am raising a big question. Should we treat the patient with cytotoxic, yes or no? That's all.
Okay.
Yes,
Dr. Ibrahim.
Coming to CLL, we have to be precise. And I agree that Fadi Farhat Fadi definite fazili. Let us be clear. Is right. He wants to to have some clear answers. First, we have chemotherapy, immunotherapy in CLL, I think it is dying. We have target therapy, including venetoclax or BTK, and now, and anti-CD20, the old and the new. And venetoclax is here, ibrutinib is here, and in the near future also, acalabrutinib will be here, and zanubrutinib, and other also combination phase 3 studies are ongoing, comparing the one to the other, the combination to the others. Now, regarding venetoclax, we know that with shorter time than ibrutinib, because ibrutinib is response dependent. You stop, the patient progress. You have to continue ibrutinib over years, and this is cost effective. This is not cost effective like venetoclax over sometimes. So we have to to design something very interesting for the country, including the modality of therapy and the modalities of MRDs. We know that in CLL14, you have a kind of a plateau with a significant MRD until, for the majority, until 16 months, 15 months, and if few patients progress after the MRD, and slightly until 18 or 24. And many patients does not relapse, as Dr. Colette said. So MRD is here. With flow cytometry in our country, it's acceptable. If we can develop NGS and more NGS, and it is in development, it could be also a good thing. Now, if we design a national program or a multi-center program for the government who is paying the drugs, or NGOs or other, well, saying that we have to use this drug in this combination and to the MRD every 3 to 6 months with flow cytometry, multiplex, and NGS. And in this case, we will have, if we have the same CLL14 curve, the same things or similar, we are in a good track. Now,
that's what Dr. Attan proposed, NGS.
Yes, but NGS, don't know NGS. NGS is not the end of the world. If you have many people are doing flow cytometry and arriving to 10 minus 4, 10 minus 6 with good result, good PFS. So this is not the major issue. This is an issue. We can discuss NGS. It is the factor. In this case, if we do a kind of multi-center homogeneous, the cost of the flow or the cost of minimal residual disease evaluation will be lower because the patient will be treated homogeneously with regular tests done with less أكيد لأنه it will be a package. This is very, very important. Now, what we have to use, we have أكيد to use more target therapy, not alone, I think. بالنسبة venetoclax alone, venetoclax plus anti-CD20, venetoclax probably plus ibrutinib in the highest risk, because ibrutinib, venetoclax in the CLARITY study or in the first line therapy it is 90% MRD negativity. So we have to say these patients will be treated by this type of treatment. This patient by other combination, targeted therapy for the majority plus regular MRD every 3 to 6 months to see our experience and to see if we have the same result that the others. And I think this is very important for the patient, because the patient will be treated homogeneously with the same chances to be cured or to be functional cured. This is important to sit and discuss.
I totally agree. I totally agree that we need to focus. Yes, of course. Sorry.
Yes, Dr. Farhat. Yes, Dr. Farhat.
I want to take back the discussion. The discussion لمحل ما كان بده ياخذها دكتور غصن. It means the health economy. هلا for the payers, the best patient is the one who is dying or who is dead. لأنه هيدا أوفر شيء. نحن the problem بلبنان إنه we don't have the perception of society. يعني when you are curing a patient, this patient is working and il est rentable, عم بينتج مصاري.
Producing, okay.
You pay more, you get more.
Yeah.
That's the problem. But it's not the case. The insurance is paying, the patient is not participating directly. That's the problem. واحد. اثنين, أنا I totally agree على اللي قاله دكتور أحمد إنه ودكتور بيتار كلكم ودكتور جوزيف. Yes, we need to do a يعني شو بسموها workforce. يعني to decide
task force.
task force جماعة بين workshop والتاسك فورس. التاسك فورس
workshop in a task force.
اوكي برافو احمد جماعتها. واي نوت؟ بس بده يكون
وين اختفيت يا دكتور احمد؟ بدنا نشوفك.
طيب
can do it لانه we need at a time to introduce the health analysis بالديسيجن. we understand well. اصلا كنا عايشين على الدين، سوري عم نحكيها هيك على الهواء، بس كنا عايشين على الدين واوفر. بس ما في شك انه we cannot skip this drug. يعني I had a discussion with someone قال لي كيف تتصور يصير الوضع الطبي بعد الايكونوميكال كرايسيس. قلت له I'm not afraid لانه الاساس هو الجسم التمريضي مع الجسم الطبي، واتس اكسلنت عندنا بلبنان. الماتيريال عندنا we have sufficient for 5 years. مشكلتنا بالدراجز. so we have to reinvest يعني to redesign. بس كنا بنعرف مثلا قد ايه بنروح مصاري على الانفستيجيشنز اللي منا كثير مطلوب. يلاحظوا الانشورنس كيف بتدفعنا، كيف بتوافق على بعض الاشياء، بينما مؤسسات ثانيه بتوافق على كل شيء. نحن we have to redo everything. بس انا ما عندي اي شك انه we will still use these drugs. so now the idea is how to use it better. هذه it need a task force، وهذه it need يعني الانستانس بدها حدا من الوزاره، بدها حدا من الدوله يمشي فيها هيدي، لانه it's true we cannot يعني
ايه دكتور ابراهيم؟
بس
تفضل احمد.
you have to go with the facts. we know that ibrutinib produced longer PFS but in front line, but you have to continue بيصير غالي. venetoclax بس خلينا نشارك. venetoclax obinutuzumab is a new standard on front line. venetoclax rituximab is useful in relapse and بيبقوا هوديك الباقيين اللي هن منهم كتار كتير. so we can have a consensus on this.
بس انت بتعرف تعمل نحن بنعرف انه في الاتيودات يلي بتعمل شيء اسمه كوالي عليهم لهيدول.
Yes.
So do you have any quality evaluation of for these two drugs, for example?
No, it is not clear.
I'm asking.
لا, there is not a good quality لأنه those are recent studies and simultaneous ورا بعضهم. أوقات بتكونوا عم تخلص أنجأ نص وحدة شوية بتكمل الثانية. يعني كيف؟ يعني MD Anderson was going fast بعدة studies و simultaneous studies. the latest one is ibrutinib plus venetoclax اللي هي أحسن شيء in very high risk patient وأحسن شيء بالMRD negativity. نحن يمكن ما نوصل لهم patient.
Sorry كمان if I can say كمان نحن we must not forget that these patients are elderly. يعني maybe we will not arrive to a second line. Maybe they will die from other conditions.
Yes, but
so let's use our يعني it would be intelligent to use a front line that is fixed.
An intelligent, efficient, durable response MRD in first line. Hey, you spare the second line and you spare paying money for second line.
No, because lots of the patients are 80 years sometimes or 82 years.
Let's hear you, Dr. Khatib.
Marwan, can I ask, if you allow, a classical question in our daily practice, لأنه we are now going so far in the future وهيك. About the
and we only have 5 minutes. Okay, so
about the TLS.
We need to be practical.
About the TLS, how serious is it? In fact, in daily practice, we are
facing it.
We are dealing with the TLS in inpatient. We are following the recommendation, or in practice, it's not serious as it's shown in the literature. So you have the experience of the venetoclax in CLL. Is it really a problem to take into account, to hospitalize the patient, to worry about, or it's written in the wordings, but in practice we don't have as much as TLS as it's written in the literature. So what you can comment, Colette, for instance, or
yes, in fact, in fact, for TLS we didn't have as serious adverse event as in literature. We know how to ramp up now, and now we have the other criteria اللي هي البiochemical TLS before entering into a real TLS, in fact. So if we follow with the biochemical TLS,
as outpatient, we are handling as outpatients, usually.
90% of the patient. I didn't have to hospitalize. هلا ما حدا منا بفتكر عنده like 100 patients or something like that.
But it is less complicated than
less
complicated.
I didn't have to put anyone in the hospital for the TLS due to venetoclax, in fact. And we have a series of criteria that we can use before even ramping up, in fact, the dose to see if you want to have a hospitalization before. So it's really manageable. And the only problem that we have here, I think, is we don't have the fast take. This is the only problem that we have. Not really the TLS.
You have it بس غالي كتير. بس ما بتستعملي كتير
يعني. Marwan, also can I have also a small questions for both?
Of course.
The panel of mutation that we are looking for, and the classical one, P17, IGHV, etc., 14. We are doing this since it's reimbursed at the diagnosis. So at the period of these patients don't need intervention in the wait and see period. Is it recommended to do it at the wait and see, or it's better because some in the literature it's better to
it is not recommended
because deletion will appear. So that it's a clear. It's better to avoid it at the beginning since we are repeating it at the progression.
The IGHV, I don't think we have to repeat it.
It is not.
Correct me if I'm wrong, but I think it does not change with time. The IGHV, but
yes,
the deletion
it don't change with time.
Yes, but the deletion 17p
هذه variable status do not change with time.
Yeah, so
we heard you, Dr. Bitar. We hear you.
Okay, the recommendation is not to do anything, any molecular test at the beginning. Yani when you see a CLL patient, stage 1, for example, it is not useful to do it. Only unless the patient will be in a clinical trial later on. If he is followed inside the clinical trial, you need to do the P53 status at the beginning of the treatment with the mutational status of immunoglobulin heavy chain. When the patient recur or progress, we repeat only P53 disorder. We look for any change in the P53, but we don't repeat the mutational status of immunoglobulin heavy variable gene.
بس دكتور بيتر بس
I would like to add something. تفضلي.
Yes, Dr. Bitar, final comments.
لا Colette
then what you wanted to say. Final comment, then we'll go to the other participants for their final comment.
أنا كان بدي بس أقول شغلة إنه it's not true إنه الباير يعني أنا مش عم بحكي as a payer but as a يعني شخص عاشرهم للباير ومشي معهم وشافهم كيف بيفكروا على مدى حوالي 20 سنة صار لي بيشتغل معهم وعن قريب كتير. it is not true إنه بفضلوا إنه المريض يموت يعني أو إنه إذا المريض أحسن لهم لحتى ما يدفعوا كتير مصاري أو شيء منه. مش مظبوط. بس
you will have to respond دكتور فرحات. خلي دكتور يخلص.
بس المشكلة الكبيرة هي بعدم الثقة اللي موجودة بين الباير وبين البريسكرايبر. That's it. بس.
Fine. Thank you, Dr. Bitar. Thank you, Dr. Bitar. Dr. Farhat, you will have the last comments because the conclusions are from you. So let's go to Dr. Final conclusion Dr. Farhat. Now, Dr. Colette, Dr. Hanna, your final take-home messages. We, the lay people who are hearing you, all this discussion, give us a final message.
I just wanted just to say to Dr. Attan, if I have a young patient, even if it's not recommended, I would do the P53 or the deletion 17p.
It is for follow-up.
It is for follow-up.
If you do it in diagnosis, you have a closer
Dr. Ibrahim, let everybody give his final comment. We are on virtual, we cannot
لأنه
intercommunicate.
قلت لها ده
Each
لاست أقول
person.
أنا هحط الجملة
انت ترجع بتحكي هلا من بعدها لدكتور اكولات رح خليك تحكي مباشرة. لا دكتورة حنا خلصي إذا بتريد.
Like Dr. Ibrahim said, now, in fact, I would do in young patient a deletion 17p, even if it changes with time, because my follow-up will be very close. And it's important to know if you have a deletion 17p, even if it's not in the guidelines, even if it's a stage 1, it can goes very quickly into a stage 3, and we will have to treat very quickly.
Yes.
Very good. Dr. Ibrahim, you can now give us your comments. Other comments, other take-home message.
I don't have another comment, and I intervene to confirm that what Colette said is true.
But on the whole CLL issue, one take-home message for us.
CLL with a new targeted therapy must be considered like CML, a functional curable disease. We have to take into account that patients in CLL in our countries are younger than in others. And also we have some bad prognostic factors that are more frequent than in others. We have probably more P53, 17P than abroad. We have younger patients than abroad. We are collecting the CLL in the area to see epidemiologically how is it in our countries. Probably younger patients, probably poorer prognosis than in the United States of America and in Europe. So we have to take this into account in order to manage, in order to establish our protocol for follow-up for MRD and for treatment.
Dr. Khattab, your final comments.
I'm not.
We hear you.
So it's very interesting. So the CLL, like I said, when we were in our training as fellows, and we remember that this disease was the disease for the elderly, and the aim of the therapy was the supportive care. We give chlorambucil, cyclophosphamide. Donc nowadays we return to the oral forms. We're still giving oral with a different mechanism, and we are hoping cure by the MRD. So the history, the concept of the disease is changing. The evolution of during this era, the CLL is doing it's booming, let's say.
Thank you very much, gentlemen. Before giving the final comment to Dr. Fadi Farhat, I would like again to thank you all for your very nice participation, to thank our support, AbbVie, and to thank our also technical support, Science Pro, to thank the AMAAC and the support of Dr. Sami Khatib, and the last word is for you, Dr. Farhat.
Thank you very much for everybody. Really, it was very interesting, very nice discussion. For sure, Dr. Nizar, directly, it was an example what the people say, but طبعا insurance are interested. CLL is really, in my opinion, transformed from a chronic disease to almost curable, and I would like to use the word curable disease with time, like we should use it in CML, probably, we'll see. It was very interesting. We learn always something from this discussion. All presentations were excellent, and the discussion was really very nice. Thank you very much, and see you in 3 weeks almost for Women and Cancer session. Thank you
very much.
Nice.
Thank you. Bye-bye.
Thank you. Thank you. Bye.
Thank you. Bye-bye.
Thank you.
يعني أول شيء كتير بزعل، وتاني شيء بحس حالي إنه الشخص اللي بوجهي بده يتعالج يمكن أخسره.
الموت. بعرف وحدة كان معها لوكيميا وصحت.
كانسير دو سون، يعني شو بده يفكر إنه كل المرضي مثل الكانسير تبع كل شيء، كانسير دو سون صار بفتكري عنده
كثير علاجات.
اللوكيميا هو كانسر بالدم، هيك بسمع. بس يفوت بهالدومين بده يبدو الدم بده يجي وقت ويتوفى.
شيء بيرعب، شيء بخوف. الله يساعده اللي عنده.
فكر بشاب صديق توفى من شهرين.
الله يشفي الجميع، وإن شاء الله بصير عجوبة بيلاقوا العلاج كليا، ما حدا بيموت من هالسهولة من هالمرض.
يخطر على بالي انه الشخص بده يقطع بتراجيه بحياته شوي صعب، واكيد الناس اللي حواليه بده يكونوا بيك سبورت له.
وبزعل شوي زياده هلا لانه they have to go through الكورونا زياده، يعني ديجا هن ما كثير بيكون عندهم مناعه، مع الكورونا it's even more.
شو بدنا نتعالج دغري، شو بنخطر على بالك؟ بدنا نروح عند الحكيم ونتعالج دغري، خاصة عند الكبير بالعمر مثلا.
مرض سرطان الدم، هلا السرطان هو مرض خبيث بيصيب على اي منطقة بالجسم.
قبل كل شيء بقول له الله يشفي. مرض ضرب بالدم وخطير، نحن هيك بنفكر فيه.
هلا هو بشكل عام الكانسر كله كفكرة بتخوف بس تسمع بهذا المرض.
كانسر حتى ايفن اذا قالوا لك مثلا براست كانسر بتقلب بالارض، هي كلمة كانسر اذا حدا قالوا له شو برجك بيقول لهم برج السرطان، كش برا وبعيد، عرفت؟ هي هيدي من هي شو بيقولوا له هذاك المرض، هذا بدها تضل هيك لانه الكانسر معروف انه اخرته موت.
بتمنى يصير في علاج له وترتاح العالم، بكفي انه ترتاح نفسيا العالم انه في علاج مثله مثل اي عوارض ثانيه بالجسم.